Welcome. In this fifth session on infectious uveitis, we are going to talk about mainly helminthic uveitis. And the important topics here are toxocariasis, cysticercosis, and diffuse unilateral subacute neuroretinitis. Ophthalmomyiasis, which we will be talking at the very end, is not due to helminth but is due to the fly larva. Toxocariasis is caused by the roundworms Toxocara canis and Toxocara cattai. Dogs and cats are the definitive hosts and harbor the roundworm in their intestine and pass the eggs in their feces. Humans, usually children, acquire infection through the oral route upon coming in contact with contaminated soil or food or infected animals. In the human intestine, the eggs become larvae and migrate hematogenously to various tissues. However, humans do not pass eggs in the stool, so stool examination is not helpful in detecting Toxocara. Clinically, Toxocara can occur in two forms. We have the visceral toxocariasis and we have the ocular toxocariasis, and these two rarely occur simultaneously. Ocular toxocariasis occurs in older children and do not have significant eosinophilia. Ocular toxocariasis, all three are typically unilateral and demonstrate the typical white reflex seen in retinoblastoma. 25% of ocular toxocariasis present as a chronic endophthalmitis, another 25% present as a posterior pole granuloma, but the major form of ocular toxocariasis is the peripheral granuloma, occurring in half the patients with ocular toxocariasis. Chronic endophthalmitis presents with an unilateral dense vitritis with or without cyclitic membranes and may have associated granulomatous anterior uveitis. In the posterior pole granuloma form, there is a solitary white elevated lesion in the posterior pole with traction bands extending from the mass to the surrounding retina. Initially, there can be associated significant vitritis, but the vitritis later subsides with time. The most common form is the peripheral granuloma form, in which we get granuloma in the periphery, which is also a solitary whitish mass occurring unilaterally. And from this mass, there are traction bands in the vitreous extending posteriorly towards the macula, and these cause retinal folds or tractional retinal detachment, dragging the macula towards the peripheral granuloma. Other forms of ocular involvement has also been described in ocular toxocariasis, including intermediate uveitis, granuloma on the optic disc, and diffuse unilateral subacute neuroretinitis. Diagnosis is essentially clinical, serology is unreliable, PCR is not readily available, Goldman-Whitmer coefficient can be analyzed, and an USG B scan helps in differentiating from retinoblastoma. Toxocariasis may show vitritis and vitreous membranes, but there will be absence of calcification, which is characteristic of typical retinoblastoma. Complications of ocular toxocariasis include vitreous opacity, cystoid macular edema, and tractional retinal detachment. Treatment of visceral larva migrans is with oral albendazole. However, in ocular toxocariasis, role of anti-helminthic therapy is uncertain, and periocular and systemic steroids can be instituted to control existing inflammation, followed by vitrectomy if feasible for a tractional retinal detachment. Coming to the next ocular helminthic infection, cysticercosis. It is the most common ocular tapeworm infection caused by Cysticercus cellulosae, the larval stage of Taenia solium or the pork tapeworm. Humans acquired the infection by consumption of contaminated vegetables and water, and also consumption of undercooked pork, and larvae penetrate the intestine and disseminate hematogenously. Ocular infection usually affects children and young adults who easily acquire the infection, and it can infect any part of the eye or the orbit. So there can be an eyelid cyst, a cyst in the subconjunctival space in the anterior segment, but the posterior segment is most commonly involved with a subretinal cyst. An intravitreal cyst can also be found. So we find a cyst of Cysticercus here. The lesion is initially subretinal, then may penetrate the retina into the vitreous cavity. Subsequently transforms into a subretinal or intravitreal translucent cyst, which is globular in shape. And within the cyst we find a dense area representing the invaginated or evaginated head or scolex of the larva, and this dense area or the scolex undulates on exposure to the examination light, which is very characteristic of Cysticercus. Complications include retinal detachment or severe panuveitis following death of the larva. Cysticercosis can also involve the CNS, which is a serious condition, and the patient presents with fever and seizures, and on examination intracerebral calcification or hydrocephalus can be found. Cysticercus also involves the muscles and the subcutaneous tissue. So diagnosis is essentially clinical, but a B-scan can be done showing the cyst with the eccentric undulating scolex, and B-scan is particularly helpful to detect the cyst in a patient with panuveitis following larval death. And neurocysticercosis reveals coin-shaped lesions with perilesional edema. In ocular infections, antihelminthic should not be given because it may kill the larva, causing panuveitis, which can be very severe. Laser photocoagulation should not be done as well for the same reason, and the only treatment for ocular cysticercosis is surgical removal. However, non-ocular cysticercosis such as neurocysticercosis should be treated with antihelminthics like albendazole and praziquantel as well as systemic steroids. And when ocular and neurocysticercosis coexist, the ocular cyst needs to be removed first before instituting treatment for neurocysticercosis. Diffuse unilateral subacute neuroretinitis or DUSN is also called unilateral wipeout syndrome, and it is caused by motile nematodes that migrate in the subretinal space. So a nematode migrating in the subretinal space is responsible for diffuse unilateral subacute neuroretinitis. And the typical nematodes involved are Ancylostoma caninum and Beliascaris procyonis. However, other organisms such as Toxocara canis has also been implicated, and DUSN usually affects young adults. So the patient presents with an unilateral insidious vision loss, and in the early stage we get a triad of moderate vitritis, optic disc edema and multifocal grey-white subretinal infiltrates in post-equatorial retina. So we get moderate vitritis with multifocal grey-white subretinal infiltrates and optic disc edema, and the subretinal infiltrates are transient and recurrent and occurs in clusters near the worm. The red circles in these 5 photographs identify this migrating subretinal worm. So worm in the subretinal space may or may not be detected, and larger worms tend to produce subretinal tracts of RPE degeneration, and smaller worms tend to produce focal infiltrates and scars. Late stage of DUSN resembles retinitis pigmentosa with pigmented retinopathy, optic atrophy and arteriolar attenuation. Diagnosis is clinical, and subretinal worm clinches the diagnosis. Fluorescent angiography shows optic disc leakage with increased background choroidal hyperfluorescence, and ICG shows hypocyanosis of the focal subretinal lesions. OCT shows thinning of the inner retina including the RNFL with loss of the foveal depression. ERG typically shows a reduced B wave corresponding to the atrophy of the inner retinal layers, and eosinophilia can also be detected. Prompt treatment of DUSN saves vision, and laser photocoagulation of the worm in the early stages is the treatment of choice, and laser photocoagulation does not provoke inflammation, and antihelminthics may help to immobilize the worm for laser treatment. Onchocerciasis or river blindness is endemic in Africa and Central and South America, and the causative agent is the microfilaria of Onchocerca volvulus, which is transmitted from humans to humans by bite of the black fly, and the black fly breeds near rivers, so it is called river blindness. In the eye, the live worm can be seen in the anterior chamber, the vitreous cavity or the cornea, and there can be thickening of the eyelids, conjunctiva or the orbit. Corneal involvement can cause nummular keratitis. Anterior uveitis associated with onchocerciasis is characterized by plastic iritis with iris edema, and the appearance of the iris is said to be like spongy pumice stone. And typically anterior chamber exudates are located inferiorly in the anterior chamber and distorts the pupil, so we get an inverted pear-shaped pupil, which is said to be a characteristic of onchocerciasis. Chorioretinal scarring and optic atrophy can also occur in onchocerciasis, which can be severe, and this is the main cause of blindness in onchocerciasis. Diagnosis of onchocerciasis can be arrived at by biopsy of involved skin or superficial ocular tissue in a suspected patient, And treatment of onchocerciasis involves ivermectin, which kills the microfilaria, and doxycycline, which kills the adult worm. Gnathostomiasis is caused by gnathostoma, and it is acquired by ingestion of semi-cooked fish of dirty drains. Ocular manifestations can be caused by the migrating worm or the inflammation. The worm has a hook-shaped structure, and when this hook penetrates the ocular tissues, iris hole, retinal tears, choroidal and retinal hemorrhage, and lid swelling can occur. Anterior uveitis and chorioretinitis can also occur as an inflammatory reaction to the worm. Treatment of gnathostomiasis is removal of the worm from the eye. Pediatric presumed trematode infection is caused by the trematode Phylophthalmus, and the infection occurs upon exposure to pond water, and cases have been reported from South India. Ocular features include subconjunctival nodules, anterior segment nodules, and granulomatous anterior uveitis. Posterior segment involvement is rare. Ophthalmomyiasis is caused by fly larvae or maggots, and the eggs are deposited by the fly on eyelids or the conjunctiva. In ophthalmomyiasis externa, lesions are found in the eyelids and or conjunctiva, and in the ophthalmomyiasis interna variant, the larvae pass to their second stage and penetrate the eye and or the orbit, and we get subretinal tracts of RPE damage, small conjunctival hemorrhages, and uveitis following death of the larva. Thank you for listening.